Good day and welcome, everyone. Thank you for joining another episode of the Microbially Speaking podcast. If you're a returning listener, welcome back. If this is your first time joining us, then welcome. I'm your host, Kevin Stinson. So I'm shaking things up a wee bit with our format this week. First off, here I am for the first time on camera, so that's exciting. Trying to give a little bit more of an interesting twist to just staring at a static logo for 20 or 30 minutes. Now, I do realize that if you're listening on Spotify, this is a remarkably unchanged experience for you, and I will continue to put out audio-only episodes on Spotify. But I wanted to do a little bit more of a little bit more of a visual enhancement, if you will, for anyone who wants to join on YouTube. And certainly as I develop some of my video editing and video formatting skills over the coming weeks and months, I'm hoping to look at how can we really make this a more interactive or more engaging experience. Certainly, if you have any thoughts, any feedback, anything you'd like to see change with the format, let me know in the comments below. I'd love to see how we can make this a more fun, more engaging, more dynamic experience for you as a listener. Now, the other thing I'm trying this episode is to be a little bit less scripted. Past three episodes have felt very rigid. They felt very much like I'm reading a book. And I realize that when I go and do a talk in person, that's not how I present. I don't present with a very rigid script in mind. I kind of have a general sense of what I want to say, and I just sort of hop up on stage and improvise around that. And so I want to bring a little bit more of that genuine kind of style into this podcast and be a little bit more unscripted, a little bit more loose, a little bit more fun in how we present some of this material. Now, it is Tuesday here, Tuesday the 26th of March, and I'm here for day two of our IPAC Canada 2026 conference here at the Toronto Weston Harbour Castle Hotel, downtown Toronto. What an amazing conference it's been. What an amazing turnout we've had. 50th anniversary of the organization. We have 1,000 people in person here, representing people from all across the world, hundreds more attending online. Incredible turnout this year. And I do have to say a special thanks to those who have come up to me and say, as listeners to the podcast at the conference, to give me some thoughts and to just let me know you're listening. It means a lot to hear that what I'm saying actually resonates with people. So thank you so much for being a listener and for coming out and chatting with me at the conference. Now, that said, there's a topic that is underpinning a lot of conversations so far, and that is we are yet again turning to a large multinational outbreak of a rare and severe infectious disease. And in that, we're absolutely talking about Ebola. So let's turn today to look at the Ebola outbreak that's currently happening in the Democratic Republic of the Congo and in Uganda, and unpack a little bit about what exactly is going on there. Now, before we dive into that, it is important to talk about a little bit about the Ebola virus itself, because like hantavirus, and like what we talked about a few episodes ago with hantavirus, the term Ebola has this really weird mix of what common language is versus scientific naming conventions. So if we recap with hantavirus, we use the term hantavirus very broadly. But hantavirus actually refers to a family of viruses. There are multiple different hantaviruses. So the outbreak on the cruise ship on the MV Hondius right now is linked to a specific virus called the Andes virus. That is a different species than other hantaviruses, including than the Sinombre virus that we have here in North America. If you haven't checked out that episode, I will link to it in the description below. Be sure to check that out. Great episode. So let's talk Ebola then. Ebola has a very similar concept. The term Ebola is thrown around very loosely, but it actually refers to a group of 6 ebolaviruses. They're all viruses within the genus Ortho-ebolavirus. Now, three of those, um, is what's responsible for the most large-scale outbreaks in most human disease. And so that is the Zaire virus, that is the Sudan virus, and the Bundibugyo virus. That's the one you have to say 10 times fast to really, really get the feel for it. Bundibugyo virus. The other ones are certainly Ebola viruses by name, but they aren't associated with human disease, or if they are associated with human disease, it's a much more attenuated, much more mild illness. Now, of these Ebola viruses, when we hear the name Ebola, we typically refer to the Zaire virus. That is the one that has the most significant disease. It's also the one that has the most significant widespread outbreaks. But it is really important to understand that these are separate viruses. They're separate species of virus. And that's really going to become important as we unpack what's happening right now in the DRC, and try to understand what's going on down there. Now, Ebola is endemic in a lot of countries in Africa, but the reservoir of Ebola, where it lives naturally, is still not really well understood. The best thought right now, the best assumptions is that Ebola lives as a silent infection in a reservoir of fruit bats. And that would make it very similar to Marburg virus. Marburg virus is another filovirus, very similar virus to Ebola, causes a lot of similar diseases to Ebola, and that one's found in the Egyptian fruit bat. And so the thought that the expectation, the scientific assumption right now is that Ebola is also found in fruit bats. And much like what we saw with rodents and hantavirus, the assumption would also be that Ebola survives as a asymptomatic colonizer, an asymptomatic infector of these fruit bats. Now, the virus is likely shed in urine and feces of these bats, and it relies again on that idea of asymptomatic colonization, silent infection, and large population density to allow it to propagate, to allow it to spread, to allow it to continue to continue to survive. Now, humans become involved in this either directly from bats. We walk into a cave, for example, where you have fruit bats up above, and you have the bat guano, the urine and the feces raining down on your head, and that's how we could get the virus. Or non-human primates go into one of those environments. They get exposed to the virus and they become infected, and then humans become infected from them. A big challenge we see in Africa is the consumption, the use of non-human primates as bushmeat, especially in rural communities. And so when a non-human primate becomes infected with the virus, they're harvested for bushmeat. All of that infected blood, saliva, urine, feces, whatever, that is then exposed to humans, and humans can become infected. So the virus enters us through mucous membranes. So think your eyes, your nose, your mouth, basically any wet surface, or through non-intact skin. So directly into non-intact skin. And then it has a little bit of an interesting process once it's in the body. So the virus first infects immune cells called monocytes. So this includes macrophages and dendritic cells, and both of these are what we could think of as a first responder cell. They're both cells that would typically be brought in to seek out and destroy pathogens in our immune system, that first phase of immunity. Now, normally when our body encounters a virus, it also then creates a cytokine called interferon to help then moderate that infection. The goal here is to release interferon to signal other immune cells to say, all right, we have a virus here, we got to work on this. Let's release it. Let's work to control the infection. Let's work to limit replication. Let's look to kill off the virus. Let's look to really knock down spread. But when we look at the three Ebola viruses that are capable of human disease. So again, that's Zaire, Sudan, and Bundibugyo. They have a really cool ability. Cool? Unique? Cool. We'll go with cool. They have a really cool ability to evade that host immune response. They block the interferon response and, in essence, shut down that immune response. And that's really important because in when we look at the other Ebola viruses, the ones that don't cause disease, these ones don't have that same ability to modulate and shut down and evade the immune system. They infect a person, or if they infect a person, they're very quickly recognized and eliminated, very quickly taken out by the immune system. And so that ability to evade the immune response, that ability to shut down interferon, becomes a really important aspect of what causes disease with Ebola. So not only with Ebola do we have this idea of it infects our first responders, but it also shuts down the ability for our first responders to call for help. And that's a huge factor in how Ebola causes disease. Now, once it's in our immune cells, Ebola has pretty much free reign of our body. Our blood will traffic it all throughout our organs. It enters into our lymphatic system, which will also traffic it all throughout our organs. And it can get to virtually every aspect, every tissue of the human body. And here's another unique aspect of these viruses. They're not picky when it comes to what cells can they infect. They can infect pretty much any cells of the human body. A few limitations, of course, a few restrictions there, but certainly a lot of different tissues. You're talking liver, you're talking spleen, you're talking skin, blood vessels, all of these tissues throughout the human body. So once someone becomes infected, the virus will incubate for up to 21 days prior to someone's developing signs of infection. And then they launch into this very typical general fever, flu-like illness presentation. And that rapidly starts to progress over 1 to 2 weeks. It rapidly grows, expands, progresses to develop into a multi-system organ failure. Now, inside the body, the virus is replicating. It's replicating again indiscriminately, looking at multiple different tissues throughout the body. And that causes a few different things to happen. For one, it causes direct cell death. It's replicating in cells and killing cells of multiple different organs through the body. But it does something else that's really cool. And this might be a term you remember from the everything we saw with COVID-19, which is the idea of inducing a cytokine storm. It kicks the immune response into overdrive by massively releasing cytokines, signaling molecules that activate the immune response. And it causes widespread inflammation. Of course, widespread inflammation starts to cause widespread tissue damage. We start to see damage to the liver. Damage to the liver impairs the ability for the body to produce blood clotting factors and platelets. We start to see damage to the kidneys, shutting down the ability to eliminate waste products. We start to see damage to blood vessels. Damaged blood vessels start to leak fluid out of the capillary beds into the tissues. Again, similar to what we see with hantavirus on that regard. But eventually that combination of liver failure, cytokine storm, blood vessel damage, it all leads to a condition known as disseminated intravascular coagulopathy, DIC. And what that means is, in essence, the body has all of our clotting factors, all of our clotting systems simultaneously activate throughout all of the vasculature. That's the term intravascular. And it uses up all of those reagents. It uses up all of those resources. And the liver's damaged, so it can't start to replenish some of those resources. And so without the ability to clot, we get patients who then just start to bleed uncontrollably. Any small tear, any small injury, they just start to bleed and they cannot clot. And that's where we get the term viral hemorrhagic fever from. This idea that a virus causes this severe fever, flu-like illness, and it eventually progresses to the state of widespread disseminated intravascular coagulopathy, DIC, and patients die from multi-system organ failure or this inability to clot. Now, Zaire virus is the most significant cause of this disease. We already talked about it is the most common cause, but it is also the most significant from a perspective of severity and mortality. Some reports and outbreaks put it as high as 70 to 80% case fatality rate, and that's incredible. 70 to 80% of cases with the Zaire virus will die from the virus. But for all of this concept of a virus, this severe disease, that 70 to 80% death, that kind of massive cascade of multi-system organ failure, that severe hemorrhaging, this is a bit of a flaw with Ebola. So certainly it really helps to transmit. We have large amounts of virus that will be kind of oozing out of the body in our blood. But the problem is, and despite it being Ebola having a very low infectious dose, it's actually not easy to transmit the virus. Most transmission occurs in this wet phase of the disease. And that's where we see that multi-system organ failure, the significant illness, the vascular leakage, widespread bleeding. But the problem is, and this is the Achilles heel of Ebola, is that's a very visible phase of disease. And that's important for viruses. It's important for infectious disease because if something's too visible, it's easy to transmit to other people. The problem is people start to recognize it. People start to recognize the symptoms and go, ooh, that person's sick. I probably want to step away from that. No one's going to a shopping mall with Ebola and just kind of hacking up a lung in the aisle, exposing everyone around them, like we see with respiratory viruses. That doesn't really happen with Ebola. And so we get a bit of a paradox here. And this is a paradox with all infectious diseases. The more severe a disease is, the more severe the symptoms are. And so in theory, the easier it would be to transmit. But then the more severe a disease is, the more humans start to look at it and go, we need to isolate, we need to quarantine, we need to shut that down. And so it's a little bit of a double-edged sword in that regard. I recall back in the early 2000s, back when I was in grad school, there was a really fun mobile game or internet game called Plague Inc. And it demonstrates this principle really, really well. So in the game, your purpose, your mission, your job is to develop a virus, develop a bacteria, develop an infectious disease, and in essence, infect and kill the whole world. And so you pick a country or assign a country, and you start with the virus or the bacteria spreading. And over time, you can start adding new traits to the bacteria or the virus to increase its symptoms, increase its severity, increase how fast and how effectively it's able to spread. The challenge here is that if you give it symptoms that make it more aggressive, it spreads faster, but the world starts to notice, and then measures start to get put into place to shut down transmission. And of course, anyone who's played this game knows that means that Madagascar closes its ports, and you will never win the game because once Madagascar closes its ports, if you haven't infected Madagascar, game over, we're not coming back. So that's this paradox with infectious disease. Highly visible, highly severe diseases actually tend not to infect as much because it's easier to see them, it's easier to identify who's infected, and it's easier to shut down that transmission. And this is exactly why we see with Ebola, outbreaks kind of flare up fast and then die away fast as soon as we start putting in public health measures. It tends to be a very small geographical area, and it tends to be prevented from really spreading to other countries or even spreading to regions outside of one or two provinces in an affected area. So why do we see transmission at all? Well, again, we talked about that practice of consuming bushmeat, non-human primates as bushmeat, and that's a way of introducing the virus into a community. But another factor that we see with large-scale Ebola outbreaks is often how bodies are cared for after death in many communities in Africa. There's this deep tradition of the family washing the body as part of the mourning process. And when you think of someone who's died of a viral hemorrhagic fever, oftentimes they'll have a lot of blood, a lot of bodily fluids. Washing that blood and bodily fluids is a huge risk of exposure to the virus, and that actually has often been seen as a direct driver of transmission in a lot of rural settings. Now, this can easily be compounded by things like poverty, lack of access to healthcare, conflict in a region, destabilization, refugee, like displacement rather, and then with that is the mistrust in institutions, mistrust in external agencies like the World Health Organization coming in and telling people how to do things, and underlying that as well is misinformation. All of these factors really help to propagate, to spread, to worsen an outbreak at a local level. So let's change gears. Let's get back to the current outbreak in the Democratic Republic of the Congo, the DRC. So in early May, the World Health Organization became aware of 4 healthcare workers in the DRC dying in very quick succession with what appeared to be a viral hemorrhagic fever. Now, think about that. That fact in and of itself should probably start to raise some red flags. Typically, we don't see clusters of Ebola or clusters of many rare viruses starting in healthcare workers. That in and of itself suggests that they were not really the index cases. They were the tip of the iceberg. There's this concept in infectious disease called the iceberg phenomena, where the cases you know about are just the tip of an iceberg, and underneath the water is this massive populace of disease that you've never seen. And so the thought was these 4 cases are likely the tip of the iceberg, but who infected them? What kicked off this outbreak and infected them? And it's almost certainly that at some point in time they had an infectious individual that they were caring for, and that introduced it to that health center. That's where those healthcare workers got it, but it reflects that something else was transmitting in the community. Now, over the coming days from that point, from early May, we started to get more and more reports of a Ebola-like disease in the DRC, and we even start to get travelers returning to Uganda, the neighboring country to the eastern DRC, who also had symptoms of the disease. But we still didn't know what was actually causing the outbreak. Now, there's a probable factor in the delay here, and the World Health Organization acknowledges this. So, like we said earlier, Zaire virus, the most common cause of Ebola, is a very different species from our other Ebola viruses. And that does matter here because for Zaire, because it's the most common cause of Ebola virus disease, we have really good diagnostics for it, but they are specific to that specific species of virus. So often we see as a preliminary test in these kinds of outbreaks in Africa, use of a system called the Gene Expert, which could best be described as a lab in a box. You have this small little cartridge. You put a specimen in the cartridge, you throw it in the box, and the box does everything. It extracts the RNA, it processes it, it runs PCR to detect the virus. It does all of that without multi-steps, without multiple equipment, without anything. But there's a really effective test in Gene Expert for Zaire virus, but it doesn't hit the other species of Ebola. So that adds a delay because when that's negative, then it has to go to a reference lab. It has to get tested on different tests or systems. It has to be whole gene sequenced. And so it ended up taking the World Health Organization 10 days to finally get confirmation that what we're dealing with right now in the DRC is Bundibugyo, the Bundibugyo virus of Ebola. And by then, World Health Organization had also started looking at who else could be infected, and they had 246 suspect cases with 80 suspected deaths, and that was across 3 different health zones. They took that, obviously, they declared an outbreak. Now, think about how fast that spread. So in 10 days, we went from 4 cases to just shy of 300 cases. And that's a really, really fast spread. And that fact in and of itself also helps to piece together a little bit more of the backstory about what's happening, how we got to here. So the current estimate, the current hypothesis is that we had a spillover event, an event where the virus jumped out of its natural reservoir into humans somewhere back around late March or early April. And we still haven't really identified that index case. Who would have been the first person to have contracted the virus? And then from there, we likely then saw local transmission, and there's some factors in the Eastern DRC that really help to propagate the spread of Ebola and really help to understand how it spread undetected. First off, Eastern DRC, lots of people living in poverty. But that poverty is made even more perilous by the fact that there is an active armed rebellion in the area, displacing millions, triggering a severe food crisis, and this starts to set the stage for the rapid spread of disease. It starts to set the stage for very easy ability for disease to spread and challenges with rolling out vigorous public health measures and ways of counteracting misinformation. This particular region for this outbreak is also a very busy mining area. And so that further increases the unrest in the area, further increases the instability in the area, but it also promotes a lot of movement of people. A lot of people coming into the region, leaving the region, moving between communities. And so you have a lot more dynamics to kind of take viruses, take disease, and spread them around. Again, another consideration goes back to funeral rites. There's a local custom to touch the body touch the body of the deceased at a funeral or at a wake. And that's part of the farewell process. It's how you say goodbye. But with Ebola virus, that carries a really big risk. And so one of the earliest known outbreaks of the cases, or outbreaks of this Bundibugyo virus outbreak, was a healthcare worker on the 24th of April who was known to then have a large funeral where people were coming and touching the virus. And that's probably one of the biggest factors driving the outbreak is that burial rites process exposing other people. But there's another big thing here, and that's the virus itself. So this isn't that Zaire virus. This isn't the one that has the 80% case fatality rate that drives the majority of human disease and the majority of big outbreaks. This is Bundibugyo. And of the 3 Ebola viruses, it's actually the least aggressive, which is kind of good to see. It has a case fatality rate estimated somewhere around 20 or 30%. This is only the 3rd time we've ever had an outbreak of Bundibugyo virus. So what that means, though, is we also see a bigger proportion of cases having milder disease. Think back to Plague Inc., where you have milder, a less visible disease. It's easier to start to spread. And that's especially true when you add in that milder disease on top of that humanitarian crisis. It becomes really easy for ongoing transmission without it being recognized by governmental agencies, without it being recognized by the healthcare system. So that kind of gives that sense, gives that kind of purpose on how are we seeing this unidentified transmission at a local level, and who's then caring for patients? Because if someone's not accessing the healthcare system and they're sick, they're less likely to be very, very severely ill. So they're going to be cared for by by family, by loved ones, by community members. And that's a very unique thing with this lower severity Bundibugyo virus. And that's exactly what the World Health Organization found. They found that upwards of 60% of known cases are women, suggesting a really high case burden in caregivers, in people who are caring for sick people in their household or in their community. So, what's being done about the outbreak? And this is where, again, we hit a snag with Bundibugyo virus, because unfortunately, we have effective Ebola vaccines and Ebola therapeutics on the market, but they're Zaire virus specific. They're not Ebola as a genus, as a group of viruses. They are specific to by Zaire, not Bundibugyo. And so what that leaves us with is we're back to a strategy of trying to contain the virus with the basics. Identify cases, quarantine cases, put public health measures into place to prevent transmission, prevent spread, and try to dispel misinformation. Try to bring down the concept of miasma thinking, of thinking that this is a sign of death coming upon a community, and try to bring in that sense of science as to what is actually driving transmission. A big part of that is, of course, looking at how do we get better, safe burial rites? How do we get better, safe care of the body after death to prevent further transmission? Now, that concept is also what makes this very hard to implement or to rather import into other countries. And so the World Health Organization has classified this as a outbreak, or as a public health emergency of international concern, but they acknowledge fully that the risk is highest in the DRC. And that's again due to that humanitarian challenges, due to the difficulty in implementing public health measures, due to all of those factors. But outside of the DRC, there's a moderate risk that gets imported into other African countries that have the same challenges or the same general setup to allow propagation. But outside of Africa, when you think of importing to Europe, importing to North America, the risk is pretty low. And there's certainly the risk that someone, a traveler to this area is exposed, comes back. It's a 21-day incubation period, so there's that time lag. So there's always the risk that we have someone importing the virus into, let's say, North America. But we're very fortunate here. We have a well-established public health system. We have a well-established healthcare infrastructure. We have processes in place to rapidly identify and control transmission risks. And so that really plays into shutting down the capability of Ebola, regardless of the strain, being able to take a foothold in North America, take a foothold in Europe, and establishing itself and causing wide-scale outbreaks. But it is what drives a lot of the challenges we see with ongoing outbreaks in Africa. So with that, I think we're going to come to a close here today. Thank you so much for joining in. I hope you liked the episode. Hope you liked the change in format, change in structure. If you have any thoughts, throw them into the comments. I would love to hear how can we make this more enjoyable, more fun. How can we really get the most out of this format? We're going to do an episode not next week, the week after, so second week of June or so. We're going to talk about Ebola still, but what I want to talk about is the true story about how Ebola did briefly make a good appearance in the United States. True story, fantastic tale. We're going to talk about that in a few weeks. Be sure to check that one out. Otherwise, thank you so much for joining. Be sure to like and subscribe to the podcast on YouTube. Follow on Spotify. Let me know in the comments if you have any other topics you want to hear about. And otherwise, thank you again for joining, and I hope you'll join us on future episodes. Thank you for listening to Microbially Speaking. See you next time.